या वीणा वरदण्ड मण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभुदिभिः देवै सदा पूजिता सा मां पातु सरस्वती भगवती निशेष जाड्यापः।
Bring together a community of dedicated healthcare professionals, fertility specialists, and reproductive health experts to share knowledge, expertise, and best practice in IUI. We successfully conducted Mom IVF hands-on IUI workshop in Hyderabad 2022, Nalgonda 2023, marking significant milestone. Now we are carrying out the procedure in Karimnagar. With high hope at another success, with our team's dedication and collective efforts, we are confident this will be another step forward in advanced healthcare. Over the next few hours, we will delve into the latest advancement challenges and opportunities in IUI, with a focus on optimizing success rate and improving patient outcomes. Our esteemed faculty, including Dr. Poornima Durga and Dr. Rajendra Yadav, will share their expert insight and hands-on experience to equip you with the knowledge and skills necessary to enhance your practice and deliver exceptional patient care. Let's work together, unlocking the full potential of IUI and improve the lives of our patients. Thank you for joining us, and let's get started.
For giving me this opportunity, and it's like home, as I said. When I saw Rekha, I felt like home. So, Dr. Naini, thank you so much for your efforts. I know your efforts, how much you have kept to bring this workshop. We are planning since almost 3 months from now. But thank you very much for giving me this opportunity. As Naini said, probably I try to not bore you guys and try to give some good take-home points at the end of the day, so that at least the main concept, if you look at the design here, it's all about unlocking the success of IUI. So the main concept, we'll understand the key, how to unlock the success of IUI. A lot of people think that IUI is a very simple process. Just you need to take the semen, you just have to inseminate, and just wait. We give some luteal support and you just wait. But trust me, it's a very, 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 very important process where subtle changes in your probably some stimulation or your semen preparation or your insemination can definitely give results to the patients, right? How many of you are here doing IUIs? Okay, very few people. So basically, IUI is the first step any fertility patient can undergo, right? It's the first thing. We have, how many options we have in IVF? We have only 3. Juggling with these 3 processes. You try this, otherwise you land up in IVF. But if you do a proper IVF, you can reduce the patient coming to IVF, okay? So today, my session is all about practical things. I want all of you to be more proactive. You can stop me, make it more interactive session, not like a theory talk. You stop me in between. It's a workshop. So I'm going to discuss some cases in IUI where you can expect some issues or how to overcome those issues. The talk is all about that, right? Age, duration of infertility, semen quality, how do you do the semen preparation. We have a hands-on workshop in the afternoon where each and every doctor are going to prepare the IUI sample by their own. They assess the pre-ward sample, post-ward sample, how good is your sample. You have some excellent gifts coming up for the first top 5 doctors who have done the excellent semen preparation. It's like proper exam, you know, right? So I'm a bit of a strict teacher, right? So it's about semen quality, semen preparation, and the timing. Timing is very important. So what's the total motile counts? What's the indication? Do we need to take bed rest? There are a lot of questions which arise when we do the procedure. So we are going to clarify all those things today, right? So when you take about the patient selection, first important thing is evaluation of the infertile couple. Very, very important, right? So a proper evaluation itself gives you a diagnosis which procedure they have to go for. Either it is timed intercourse or IUI or IVF. Evaluation plays a very, very important role, right? In evaluation, what's the most important thing? Yes, age. History taking is very, very important. It's not like we are just taking a 5 minutes random history and going ahead, right? In infertility, the first visit plays a very, very important role. Once you know the detail, or you come to a proper plan for that patient, then you can just speed it up. But the first visit, you should sit with the patient, take a proper detailed history. At least you have to give 15 to 20 minutes for each patient. And the most important thing is, you have to see the patient as a couple. Is what I feel and I focus is on one is menstrual history. Very, very, very important. Menstrual history itself will give you a lot of information. Young patient coming with irregular periods, what do you suspect? Older patient coming with irregular periods. Short cycles being regular. Suddenly cycles becoming short. Exactly, decreased ovarian reserve. Cycle length, what's the normal average length of menstrual cycle? It is 28 days. Once the ovarian reserve comes down, the cycle length will become short. It becomes as short as 23-24 days cycle. Why? Anybody can answer? Gifts for everything today. Why the cycle length comes down as the ovarian reserve comes down?
Some of the anovulated cycles.
No, not an ovulation. Because they will ovulate. It doesn't mean that they are. What's the normal length of the luteal phase?
Short follicular phase actually. Because
Yes, luteal phase is for
14 days.
14 days. That is called for them on day 8. You're also already seeing a follicle of 18 and 20 ml. This is a common scenario we all see. That means this patient ovarian reserve come down, the quality of the oocyte is not good. Something is wrong with that. What is the minimum follicular length to get a good quality oocyte? Anybody? Minimum. At least 9 weeks. At least. If that means if you are getting a dominant follicle at least on 9th or 10th day, that means it is at least a good quality. That means you can expect that it's not a good quality follicle. The success rates of conception in that cycle might be less. So you didn't answer my question, by the way. So why the length of the cycle will come down? One is short follicular phase. Why short follicular phase? Why early LH will increase? Anybody? Because exactly, yes, in a way you're correct. The thing is, recruitment happens before periods. That is the reason. By the time you are doing a scan on day 2 or day 3, there is also already a recruited follicle by 8 mm, 9 mm. If you clearly see the scan on day 2 or day 3, you see a bigger size follicle in these people. So this is very important, small points. But it's very important how you are doing your scan, what is the scan interpretation. What we do, we generally keep a probe and see, just count the eggs and come out. It's not going to work that way. Fertility might be, looks like a very simple branch, just you do this, that, but ultimately how much success rate we are giving with IUI? What's the success rate of an IUI cycle?
10 to 20%.
We are struggling for the 10 to 50. We are not doing no justice to the patient. So whatever procedure you are doing, we should be very meticulous, observe, understand why it's happening. Then probably you may not rectify or you may not give results in each and every patient, but at least you know what to do in the next cycle. It's all about next cycle, for me at least. It's all about what you are going to do in the next cycle, how you are going to improvise in the next cycle. Right? So very important. So as I told you, I'm still at the history part. So one is, as I told you, menstrual history. Then what other information menstrual history will give you? What's the normal menstrual flow?
2 to 5 days.
3, decent. 2 is again might be a scanty flow if I say. So 3 to 5 days is a decent menstrual flow. So if the flow is less, what do you suspect? Expect a thin quality oocyte also in those people. Generally, how good quality egg gives good amount of estradiol. Okay, a good follicle produces how much of estradiol? 200, 150, 200, 250, anything around 200. So a good quality follicle, estradiol, what does it do to the endometrium? It proliferates the endometrium. Once you get a good endometrial proliferation, you get a good triple line. What you are seeing in the scan, we all talk about triple line, 3 lines. What is that basically? It's a proliferized endometrium, estrogenized endometrium, if I can say. The word is estrogenized. It means there is a estrogen development on the response on the endometrium. Sometimes the follicle will develop, endometrium doesn't pick up. We all get it. Or you see a thick, hazy endometrium. This is all because the estrogen from the follicle might not be very good. So not all, might not be all cases, but scenarios. But whenever you are seeing, you should always look at the endometrium as well. We tend to ignore the endometrium mostly. We just only go with the follicular size. Size has reached 20 or not, or 18, you give a trigger and you try. That's it. But endometrium also plays a very, very important role. And also it's not only the thickness, it also about the contour of the endometrium, right? So these are about, that's about the menstrual history. Obviously you ask about pain and all, dysmenorrhea and all, you suspect endometriosis and all. But what I feel is flow, length of the menstrual cycle will give you a lot of information, what you can expect in her menstrual cycle, or when you are stimulating her. I'll already back of the mind, I have a plan that she might be having a poor quality egg. Probably I will go with the injectables than oral in this patient. That's how you analyze, right? So we all know that injectables will give a better, so my stimulation might not, I may tell the patient that I will not go with oral, I'll go with the total gonadotropin cycle or a combination. So it will give you an idea how to plan your stimulation, apart from the other parameters. So one, as I told you, one important thing is menstrual cycle. History, everything is important, but I am highlighting few things which you definitely should insist and look for. And the most other important thing is, anybody in the history? Okay, I am going to get all the gifts. So the most next important thing is response to the previous stimulation. Very, 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 very important. Right? If the patient is coming direct to you, that's fine. But lot of patients come with already some ovulation induction or some procedure happened to them. If they're coming with that, please go through all the reports very carefully. Very, very important. Gives you lot of information. Patient already ovulated with letrozole. You're again going to start with letrozole. Lot of people do the same thing. Already she has taken almost 6 to 7 cycles of letrozole or clomiphene. She ovulated, sperm is good, still she didn't conceive. Again she comes to you and again you start with letrozole. Are we doing justice by doing that? What difference we are doing from the previous protocol? Might be if we are really lucky, sometimes it may click. But what we are doing as a doctor is there. So that's very important. Why it didn't work out there? Why already the same dose, same protocol, same follicular monitoring, same thing you're doing it. So you have to see what went wrong and change your protocol or add something which can improve the success rates of. Obviously, ultimately we are working for that 2 lines and ultimately our take home baby. So So these are two important things about history I want to emphasize on. It's a very important things which we need to all of you should look for in the history aspect. Apart from all the other parameters, all are important. Male, everything, male history, we try to tend to ignore taking the male partner history, but now as I think Rekha, everyone, Naini, everyone will agree with me, now sperm counts have come down drastically and the quality of sperms have come down drastically. We don't know, even in IVFs also where we are using, even we are going for ICSI, what we used to say the advanced technique for male factory infertility, we are still getting not good quality embryos. So sperms have gone down, I don't know, some effect with the COVID, I feel after COVID there is a drastic decline in the sperm count. So I think we need more studies in the sperm aspect. I tell Rajendra to do some studies on the male, come up with some conclusions. See, because all we work on the clinicians, we tend to ignore the lab aspect. We don't know the lab. We just, if you get a semen analysis report, you just go write the reports in your paper and just give the treatment according to it. But you should understand why it is happening. You have to go through thorough history for the male partner. Very, very important. Recently, I have attended one in Isar, one talk where there is a Aphrodite classification has come for male this thing. So I think there are 5 classes about it. All the classes they say that give HMG injections. That means we are not at all treating what we do for male infertility. Some sperm counts are low. What we are giving? We give some antioxidant. Random, and we don't know the composition of the antioxidant. We say we know only 1 or 2 ingredients in that, probably L-carnitine or CoQ. We know, but there are so many molecules in that. We don't generally look into the combination also. But that classification has come where with sir, he said that in any case of oligoasthenoteratome, you can give a shot of first HCG you give for 4 weeks and then give HMG for 4 weeks and then do the procedures. So in that way you are doing something, you are increasing the FSH, you are increasing the LH, so you are doing something for the spermatogenesis. Antioxidants, you are not doing anything. DFA, yes.
Dosage and duration,
HCG is 5,000 weekly once, okay, and HMG is 75, but he said that give at least 150. That's what the studies have been done with that dose. This is a very recent thing which I started doing. Because see, I also learn, we all learn, right? When I'm preparing for your talks, I learn a lot of things. That's how we educate, we increase our skills. It's not that I know everything from A to Z about infertility. No, it's a learning curve for everyone, even for me. Today I'm standing here and giving you a talk. Doesn't mean that I know everything. I also read a lot of papers, go through a lot of literature, see the evidence, and then I talk. So this is something which I started practicing now. Because I felt, yes, true, decent enough. See, and what is the side effect of giving a HCG or FSF? Why HCG? Because it acts on LH. So nothing wrong. It might stimulate and increase the spermatogenesis. Logic enough. So then I understood, yes, there is a logic in this. If you are treating a sperm sample, why not give gonadotropins than dumping them with 3 types of antioxidants? So that's what I learned. So I'm telling my learning thing to you all guys. So where am I actually? So that's about history, where we are talking about the menstrual history and about the treatment. Previous treatment history is very, very important to plan your present cycle, right? So these are 2 things which I want to, apart from the male history and other history aspect. So someone said about the age. Yes, very, very important. So that's all. So this becomes a very primary duty for all our gynacs to educate. Now actually all of you might be heard about DINK, right? DINK. Yes, and now I have heard again, sir of PC sir, PC Mahamatra sir, talk. He said that now DINK with a dog. Yeah, he told me. It's all about pet parents now. They are like, now all are like, they want pet parents. We are a proud parent to our pet. They feel that pregnancy is a burden for them, the kids, it's a lot of responsibility. I have in my own family, my own cousins talking that, so see, first we'll try with the pet. If we can manage with the pet, then we will try. That's what the answer came for me. So that's practical scenarios which we are facing now. The average age patient coming and approaching you for pregnancy has increased. What I am trying to say is that now, no, previously we used to get females at 20, 25, PCO. Mostly they used to come with PCO, anovulation. Periods, they're not getting proper cycles, so they want to conceive. That's the most common scenario we used to see earlier. Now, the average age patient walking to your clinic is 30. 30 minimum, in my experience, I'm talking about, these are all my practical experiences I'm talking about today, you know. So that means the average age patient coming to you has increased. So definitely, even though AI replaces or technology improves, what's the results? We are at the same success rates. Why? Because the average age has increased. Okay. Yeah. See, because why now? Minak is at 9, 10 years. Why? Anybody? Why? Exactly. There are a lot of endocrine disrupting chemicals. I read a lot about this. I had one talk about it. See, whenever I like to give talks because it is a learning thing for me also. We go through a lot of literature and information about it. So endocrine disrupting chemicals everywhere we have. In and around us we have all our endocrine disrupting chemicals. Among the most important thing is we all know is plastic. We have to, as I'm telling just now, IFS has started green IVF concept. We are starting the initiative of green IVF. I am one of the member of that group. It's a national group where it's all about sustainability in IVF clinics. You all know a simple one IVF clinic generating how much of toxins and waste into the environment. Looks very silly or funny, but there will be no future generations if we are not working today. So as a doctors, as a professionals, because for a layman it's very difficult to understand sustainability or about future generations, why we are so worried about it and all. But as a professionals, we all should make our practices more sustainable. This is one message I want to give apart from the academic thing. Sustainable practice. How we can overcome, at least from our side, from small little contribution from our side, what we can do to make our practice more sustainable. So that's one important thing. As she said, exposure to the endocrine disruptors causing precocious puberty. Girls are getting Minak at 9, 10 years. It's not healthy. So overexposure. Now kids are exposed overly to a lot of, we don't know a lot of things we reach till we reach 15, 16 years. They know everything. Our children knows what is a Minar. We really don't know. They're prepared for it now actually. So this is how it is. So as I told you, again I got stuck. So the main intention of me telling all these things is the age of the patient who are coming to our clinics have increased. They're not coming early to the whatever, gynec or the IVF. IVF though, it's like we are 35 now. We have reached probably 30 to 35 bracket. So but like, at least gynecs also. But that means you have to give the best in the first few cycles. What I'm trying, my intention of telling all these things is, you don't have a luxury of trying 12 ovulation inductions, 6 IUIs and all. See, at the time we have is, the precious time you have is 6 cycles. So let's all think about the first 6 cycles, how best we can give the success to that patient, right? So when you think about the evidence also, You see there are a lot of studies, always papers, they have different opinions and all, but you can always see that 30 years is a minimum. We can say that the success rates are much better, but 30, above 30, the ages, the success rates, whatever it is, ovulation inductions or IUIs or IVF, the success rates will come down, and also more than 35 years, the IUI success rates are very, very low. It doesn't mean that they don't conceive with IUI. You have to know how many cycles you are trying. It's all about how much success rate, how much time. It's all about that, right? That's how you unlock your success to your treatments, right? And age of the male partner. We are least bothered. Wife is 25, husband 40. Don't look at the age of the male partner. We just only look at the semen report. But what happens in the advanced paternal age or male? Exactly, very good. So that's very important. DFA of the sperm, because they are exposed to a lot of toxins, oxygen, oxidative stress, ROS and all. That doesn't come in the routine semen analysis which you are doing it. And when you observe, there is risk of miscarriage also in the male with more increased age, which we ignore. We always, when you think about RPL, which is one important, again, one more take-home message which I want to give is, RPL cases, we don't look at the male partner. So, better paternal age is also very important. So, DFA has become an added test now in a RPL category, which I do definitely agree. So, we have to look at the male sperm as well, right? So, that's about the cycles are hardly 10 to 15%. As the age increases, the success rates have come to as low as 3%, right? Next is the duration of infertility. We all know this, there is no much debate on that. Less duration of infertility, better success rate. So, average you can take it as 3 years. If they come before 3 years, you can take it at least minimum as 5 years, but above 5 years, the success rates will definitely come down. So the conception rates come down as low as 10%, right? So the categories, patients which you select for IUI should be at least less than 35 years with good ovarian reserve, at least one patent tube with good tube ovarian dilation and short duration of infertility, less than 5 years. We are good till now. Now we know which cases we have to select for IUI, right? So, I want someone to volunteer. Okay, we're all about practicals only today. Okay, so 28-year-old female trying for pregnancy for 3 years, PCO, BMI is 23, HSG tubal test is good, semen analysis is normal. They tried several cycles with letrozole and now decided for IUI. What protocol you want to keep in this patient? What are the protocols you know about letrozole? One important, I think everywhere now it's all about letrozole protocols. Yes. See, one is we give regularly from day 2 to day 3. Okay, what's the maximum dose of letrozole we can give? 7.5 mg. It's not 5, you can go for thrice a day, max. Okay. So one is regular, day 2 to day 6. One is stage step, where you increase the letrozole protocol, 1 tablet, 2 tablets, 3, 4. That's how the dose is 10 tablets. Okay. And then the most famous now going on is the extended letrozole, where you are giving letrozole for continuously for 10 days. And the one interesting paper I have seen when I am preparing for this is giving 20 milligrams of letrozole once there is a dominant follicle. I felt this is slightly interesting. That means on day 5 or day 6, if a patient comes to you, you're already seeing a dominant follicle, you can give 20 milligrams of single dose of letrozole and see. I had to try, but this is something which we can. Because there is already a dominant follicle, this helps to increase the dominant follicle. That means there is no need to cancel the cycle as such patient is coming on day 5 or day 6. This is something I didn't try, but 20 milligrams straight dose I have not given, but this is something you can try. Okay, so there's something, okay, and they are decided for IUI. So this is something, this is the protocol that they have used. Can see? Okay, they given letrozole for 5 days and added gonadotropins for 3 days. Okay, and this is the day 10, day 11 scan. Okay, clear? Can you see all of you? So what do you want to do next? Going to give few more gonadotropins. How many follicles you can expect in this? It's almost like 14 are 2, 14, 3, 5, 13 are 2. So there are almost so many follicles which have recruited. So I am not going to continue any more gonadotropins here. You are definitely going to get 5 or 6 dominant follicles in this patient. Right? So I am going to definitely counsel the patient and cancel the cycle. Or what you can do, if you have an IVF center, you can definitely counsel them for an IVF cycle conversion. That too, but first cycle IUI, this happens very rare the patient accepts. But if it is a third or fourth cycle you are doing the IUI, you can definitely counsel the patient and convert them for IVF cycle, right?
So on day 7, follicle size was not seen.
Basically it is day 10, they have not have dominant follicle, that's why they are added gonadotropins there.
Can change at 7 only, day 7 only.
Which one? What you want to change?
Follicle size.
Because the dose given is only 75. Obviously, if there is no dominant follicle here at day 7, you will give gonadotropins. Sometimes, and you can see here it is only 14 ml on day 10. It's not that they have gone to 17 or 18. So here there is no dominant follicle, or the size of the follicle is 7 or 8. You can think it as 8 ml follicle. So obviously you give 75. But here there is 13 ml. It's not that it has gone to 16 or 17 ml. That means recruited and more follicles have come. So obviously if you continue gonadotropin, obviously 13, 14 will definitely increase. See, basically the intention of telling this, taking this case scenario is you have to also see the number of follicles which are recruiting before just continuing with your gonadotropins. Right. So what's your aim of an ovarian stimulation? How many follicles you are aiming for?
2 to 3.
Yeah. So ideally the book says 2 to 3, but if you ask me, max 2, not more than that. Why? Because we don't want to give multiple pregnancies, never. If you are giving multiple pregnancies, that means we are not a good fertility specialist. A lot of people think that twins, ek baar ho gaya to ho gaya. See, but it's not easy to give a there are a lot of pregnancy. I think obstetricians can enlighten about this, about a lot of complications, and obviously the patients who are coming for IVF are elderly also. It's also elderly pregnancies for us, high risk pregnancies, and multiple pregnancy added on. So it's not. So it's better, but not, at least twins is fine, but you are not going to give triplets for sure, right? So these are the few options you have. You can proceed with IUI, add antagonist, which we are not going to do in this case, or cancel IUI, which I am going to do in this case, and ask abstinence from intercourse. I'll tell you one interesting case which I have in my personal practice. So same like this, she's a young PCO. BMI 23 is normal, right? PCO is something which are very tricky, right? You don't know how they respond. Suddenly, as she said, now Rekha is saying that what's the size at that side. So it might be small, but suddenly they respond. You never know, you might not see a recruiting follicle at that stage, but suddenly you get hyperstimulation. I had experience like that in my case. So one case I am going to discuss, one case I am stimulating. So very poor response. I have given HMG 175, no response. I generally don't go with 150 in my practice. Very rare I give 150. Patient, very anxious patient, want pregnancy at any cost. So I have given almost 6 injections of 75, no response. Then what I did, I added 150. Okay, I have given only, I think, 3 injections of 150. I got 2 follicles. Okay, 2 or 3 follicles. I have not given HCG trigger. Obviously in IUIs we don't give agonist triggers. Why? Why? Anybody? Why? Why you give only HCG triggers in IUI? Or you can give agonist? Obviously, yes, agonist, short luteal phase. The luteolysis will happen early. There won't be proper luteal phase support. HCG can support the luteal phase much better. See, in IUS, we have what pregnancies in that cycles only. When we are giving agonist, we are going to freeze the embryos or we are not transferring in that cycle. So, obviously, we give HCG. So, what happened? This is for IUI, the patient which I am talking about. I have given HCG, called for her after IUI. I have seen 6 follicles. When I am giving trigger, I have not seen. I have seen only 2 follicles. So, follicles can respond even after HCG, which I learned one thing. So then what I said, I cancelled the cycle. Okay, I said abstinence, this, that, I cancelled the cycle. So again patient came on the second day in the next cycle. Again started with letrozole. Again the same thing, no response. Again I have increased. Again I got 2 follicles. Again I gave trigger. On the day of IUI, again I have seen multiple follicles. So again I asked her to cancel the cycle. Patients are very smart. Endometrium is very good. I told them when I gave the trigger that this month it's going to work out for you like anything. Endometrium is excellent. Response is very good. It's going to work 200% this time. That's what the assurance. I'm very damn sure because I felt, see for me if I see the endometrium like a flower, I'm so happy. You know my excitement goes up. They don't know why I'm so excited, but I know why I'm excited. Endometrium I feel is so important. So I got so excited and said, so I cancelled the cycle. Patients are very smart. He is so disappointed. They had normal intercourse. I told them abstinence. So what happens? And they had normal intercourse. I told all the precautions and all. I don't know that they had intercourse and all. So then what happened? They are traveling to Hajj. Hajj or some pilgrimage. So he called me from the airport and saying that she has bloating. In the airport. In the flight. Literally, as a consultant, how you will feel. And obviously, to be frank, we are not that much with the emergencies. We are so used to going to the clinic and you got suddenly a call in the window that she is having bloating in that too in the airport. Then I said, see, I told you not to try. You tried. That's fine. Then how can you travel at this point? Then he said that no, it's a spiritual journey. We can't cancel. He's very damn, like strong-minded guy. I still remember he brings the baby to me every time, and now he's coming for the second time. I'm so very just leave. So he's now coming for the second conception. So that's how again it reminded of the whole story. So then what happened? So he's on the journey. Then I said, see, it might be a hyperstimulation, she might be having some anxieties or something, I don't know. You're describing like that, and he said that there's some rash on the abdomen or something and all. And I said that, see, they are going to Dubai from there. I said, no, you have to go to the doctor in Dubai. Please don't ignore. And she's very young lady, very beautiful. I still remember she's coming in second, but she's very like she listens to whatever husband says. She's something like that. I said that no, you have to take her. Then he got down in Dubai and he took her. Luckily, he took her to the hospital. Then what happened? The doctor there diagnosed her with ectopic. And that guy is so smart. She said she just missed her period. How can we be ectopic, madam? They are saying they're seeing the sac in the tube and all. He's such a smart guy. I said she just, and they had done the beta LCG. It is around probably 400 or something. He said with 400, how come ectopic and rupture and all? They're saying laparant and all. It's a night time. Some duty doctor said. I said no. You talk to the consultant tomorrow. Then they have talked to the consultant the next day. They have done the beta HCGs and they have evaluated and she's fine. They started her with heparin and all. She went the yatra and came back and delivered also. But you never know. Stimulations you can't ignore if you are writing a prescription. Whatever it is, monitoring is very, very important. we generally, it can happen to anybody anytime, luckily, and babies, they nicely delivered and again he's coming back. But I was like, see, this time you have to listen to me. This is for a simple IVF, this whole story has happened, okay? There's a lot of drama and everything is like a movie story. If I tell you, it will take a lot of time, but briefly it is something like this. So what I'm trying to say is, when you see more follicles, it is better to stop, but it's very important to tell the patients what to do, what not to do also. Because patients are very smart. And once you say that it's very good, they are going to it as well, whether you are equipped to convert it into an IVF cycle or not. You should always discuss the pros and cons and also the cost implications. As I told you, the risk of OHSS. Now, as we are discussing now, mostly we are doing all frozen cycles. But now again the trend is going back to the 90s. First, how IVF started. So now everyone is saying to do our fresh transfers. They say that the results are much better. Previously, we used to all do the long protocols. Now a long protocol has come back. So because the endometrium is much better in the long protocols. So they are insisting now, a lot of papers have come up where we are saying to do long protocols, do fresh transfers. So that's how it is. So I, in my touchwood, in my practice, I had only 2 cases of OHSS. One went for tapping, one managed medically. So otherwise, mostly we are doing frozen cycles. Now also I have to think back how I can, now we, as I told you about sustainability in IVF, green IVF, the concept is to do more fresh transfers. Why? Because I think the embryology team can enlighten how liquid nitrogen is made. Embryology team. So how much pollution we are giving into the environment by making the liquid nitrogen containers and the plants and all. There is a big topic about liquid nitrogen and how much toxins it is releasing into the environment. We all don't know, we are least bothered about all these things. We are just sitting, but that's not going to work that way. Today we are here today. I just want to take this message. Everyone should take an initiative. It's not like a one-man job here. I'm standing here and saying, but you all should think about sustainability and for your future generations. Otherwise, as I told you, just we are talking about after 100 years, probably there is no life on Earth. We have to move to some other planet, probably, looking for oxygen and all. Right? That's how it is. So sustainability is everything we should incorporate in your practice. So that comes at the concept of fresh transfers now. So freezing we have to come down. Cryoprotectants are hazardous. So there are a lot of toxins which are going from the IVF lab. So I'm also slowly starting it because I also do most of them are frozen cycles. Because we are used to them. But now slowly I'm starting it. I will tell my experience probably if I get a chance later. How I probably 1 year study about how my experience about fresh and frozen cycles. Okay. So that's about it. Where am I? Okay. So that's about risk of OHSS. So once you are seeing more follicles and you are not sure about whether she will land up with OHSS or not, what one investigation you can do? Estradiol, right? Serum estradiol. It will tell you about how many dominant follicles you are getting. So if it is more than 1000, it is better not to go ahead with the triggering. Okay. And also it is very important to see the small size follicles. We generally only, our aim, when we do a scan, what is a dominant follicle, we just see the size and come back. And a lot of people take only one measurement. They are not bothered to take 2 measurements also. I've seen a lot of people, just take this, okay, done. It's no need to do at least Doppler, but at least do a proper evaluation on the follicular study, what you are doing, and always look for the smaller follicles. That means 13-14 mm follicles are very, very important. If you are seeing more of 13-14 mm follicles, you please do a serum estradiol level before triggering. It gives you a lot of information. That's how you learn. You learn when you practice, you learn. There is no need to do in every cycle, but first, if you have it out, why not doing in one cycle? Holding a trigger for one day doesn't harm anything, right? So that's how you do it. So do a serum estradiol levels and then plan your trigger. So obviously, before discharge, you are not going to go ahead with the IUI or anything in this case. So what advice you give for a patient who had a slight mild OHSS? You obviously tell them abstinence, all these things. What are the new drugs which have come now? OHSS. A patient has come. You are stimulated. Normal patient. Multiple follicles developed. How do you counsel them? You are going to cancel that cycle. What are the precautions you tell to the patient? Not IUI, not IVF. Simple ovulation induction. Do happens, right? Once you are giving gonadotropins, in left and right we give gonadotropins in our practice. I have seen normal cycles giving 225 also gonadotropin in some doctors. So when you are giving that much of high doses, there is a very high risk of OHSS, right? So what are the precautions you are going to tell the patient? Very important. Yes, exactly. Very good, madam. So we are going to talk about abstinence. You are going to talk about the warning signs and symptoms about OHSS. That might be bloating, distension, mild pain, and in severe cases you have oliguria and all these things, right? So what are the drugs we have to treat? One is analgesics, antiemetics and all. Specifically, we can reduce the risk of OHSS. One is now, I think the new kid on the block is letrozole. Lot of people don't, why again you are giving letrozole? Why we are giving letrozole in the luteal phase to reduce OHSS, anybody? Anti-estrogenic. It reduces the estrogen level. So you are having a case of OHSS, you can give letrozole. One thing. Another thing is antagonist. If you are having a facility of having an antagonist, you can definitely give antagonist, and cabergoline, which we are giving since long time, it reduces the VGF factor and all. Again, one more interesting case I want to tell. It's all about, see, you guys, if you have any personal experiences also, do share, so that's how we learn from each other. You tell your experiences so that we will know how to deal in that scenario. So again, one more example. One of my friend, she, very young patient again, PCO patient, stimulated. It went into hyperstimulation. So she sent to me for a second opinion. It is a normal case of ovulation induction. Nothing, no IUI, no IVF. Very simple, newly married, might be for 1 year. So she had landed up in hyperstimulation. So she sent the case to me for a second opinion. So I have seen the case. So there are a lot of multiple follicles which are there. Then obviously, as I spoke with you today, so I gave my opinion and the patient went back to that doctor. So she is managing the case. She kept on whatever drugs and all, and she asked for her to come for scan regularly. So we don't know, they might have had intercourse. So what happened, the patient ended up in an emergency in some other hospital. What might have happened? Exactly. You're going to get a gift for me, ma'am. Definitely. See, you're going to definitely, please have to give gift to her. Okay. So, we ignore torsion. We only think about OHSS means distension, pain. If you are not having distension, you are fine. Distension doesn't happen with your ovulation inductions in your clinic. The amount of drug you are giving or the amount of gonadotropin you are giving, it might happen, but very rare cases they land up with severe or moderate OHSS. You shouldn't be worried about that. You should be, but your main intention should be a torsion. Why? Bulky ovary folds on itself and become torsion, especially if they had intercourse. There is a very high risk of torsion. And that patient landed up in torsion and had a oophorectomy elsewhere, and they came to that friend of mine and did a big hangama. Young age, losing one ovary is not an easy thing. So we have to be very careful, explain about the risk of torsion. My take home one more point message today is you should never ignore torsion. And especially if the patient is complaining of pain. Pain is something which we shouldn't ignore. Whatever it is, I say if patient says, because I know how dysmenorrhea will be, I never ignore a patient of dysmenorrhea. You can never, as we are talking about quality of life, as doctors we are here to give quality of life to the patients. We are not here to just diagnose, treat and send them. Ultimately, it's the quality of life. If you give good quality of life, the patient will remember you for eternally, probably lifetime of us. So pain is something in whatever, endometriosis, anywhere, pain is one symptom which I learned in my practice of 10 years of IVF is something. One point is pain. If patient is complaining of pain or it is increasing in tendency, that means there is some pathology which is happening. At least rule out. You might not be having or something, but rule out that pathology what it is. That's what I learned. So all know if there are severe signs and symptoms, right? So then what happened? This patient, as I said, we have cancelled the cycle, right, ma'am? So we have cancelled, Dr. Jyoti ma'am, right? So then what happened? Next cycle she has come again for IUI. So she had only one follicle. I am happy. 18 into 1, 16 into 1. I am happy, right? Now we have given HCG. Good to go. Good proper stimulation. Then what happened? Generally, as we have already discussed about this point, what number of follicles gives the better success rate. If you ask me, 2 to 3 is the thing which we are looking for. For me, it is 2. Okay? So, higher pregnancy rate with 2 to 3 pre-ovulatory follicles. So, again there is a discussion about size. Lot of discussion. When to trigger? $1 million question. Lot of people say. There are so many studies which have said that if you are giving gonadotropins, you can go as early as 16 mm. In IVF cycles also, we are aspirating a 16 mm follicles, we are getting M2s. Right? But if you are giving oral, then the maximum we can go is 20. Okay? This is something which we all know. Okay? And as I told you, endometrium is also a very important key thing which we have to look for. There are no much pregnancies is on IUI if the endometrium is less than 6 mm. There are a lot of papers about how thin is thin endometrium. How thin is thin? Less than? Huh? Depends on? Phase of the cycle, fine. Thickness I am talking about, okay. What phase? After proliferation you have secretory changes, but thickness doesn't. See, I am asking, okay, I will be more specific. What is the endometrium when you call it thin at the time of trigger, probably? That might be a correct question. 5. How many of you got pregnancies at 5 mm? That's what. 5 is good? No. Cut off. What we are looking for? Minimum is 7. 7. 6 is good. Okay, you see some pregnancies. I don't deny that you don't see pregnancies. But any stimulation which you are giving, the minimum I am looking for or you are looking for is 7 mm. Okay? Minimum cutoff we are taking is 7. Right? So that's how it is. So what happens? Ma'am, I am going to talk this case to you only. Now, IUI we are planning. Husband has come. He didn't give the sperm. Come on, embryology people. Department. Right? What to do? How to do? Okay, you're going to answer. Rajendra, come on. Yes, exactly, ma'am. One more gift to ma'am. I'm expecting some unique answers which I'm getting. I'm very happy for that. Yes. Because we all think about sildenafil first. We all think about giving some sildenafil and sending him again to give the sample. That's not going to work. Why? Erection is a psychological thing. It's all about, what is this? Mastermind controls it. You are not going to control it. It's not in your hand, doctor hands. It's in the mastermind's hand, which is hypothalamus. Endocrinology, very important. I still read endocrinology every day. Still I find something, one extra point which I don't know. Very, very important is endocrinology. Right? So mastermind is here. So you have to make him relax. As ma'am said, privacy. Very, very important. You can't send the man into a washroom and ask him to collect the sample. It's not going to work that way. Whoever are doing IUI or want to do an IUI, a proper semen collection room is a must. Right? So it's very important to have a... So basically, he failed to produce semen. Follicle ruptured. So what you are going to do? One is, as said, there are two things how to tackle this situation. There are two things. One is there are two things. One is prevention and another thing is solution. So how to prevent the situation and how to solve if you have landed up in that situation. Right? There are two aspects of it. Right? So prevention is, as discussed, most important thing is to have privacy. So counsel them, make them comfortable, make them relax. Okay, the couch should be comfortable. You can send the partner if necessary. Washing facility, very important. Very, very important. Washing facility. A lot of people can't give a sperm if they don't have a proper washing facility. These are practical issues which we all should learn about. And obviously, if you are cancelling the cycle because the husband couldn't give the sperm, you should obviously freeze the sample, one backup sample for the next IUI. So these are all preventing things. What are the solutions? Very important. This is all we know. Sildenafil with less side effects. Vibro, ejaculator, coitus interruptus, condoms, non-toxic. Home collection we don't generally advise, but in our center, if it is really difficult for the patient, we take a written consent that they are collecting and bringing the sample from the home. Consent is very, very important. If you don't take the consent later, you don't know whose sperm he brought, and if you are doing, he can again sue you. So very, very important to take a proper consultation once they are giving home. Home sample is the least thing we encourage at Mom IVF, but sometimes one or two patients, sometimes we take a proper consent, written consent from both the partners and then take the sample. Very, very important. Right? So semen collection problem is not a uncommon thing. It's not a rarest thing. We do come across these things. We should know how to prevent it and tackle the situation, and you should be able to get a solution for it. Right? So 8.3% of men experience ejaculation failure on the day of operation for IRT. So mostly in IVF, we all know and we keep a backup. IUI is a concern. So one cycle you have that experience, you definitely keep a backup sample for the next cycle. Right? So only 59% of men attending the fertility clinic felt comfortable in masturbation, and 48% required external stimulation to collect semen. It can be a partner or ejaculator, anything. Right? So we are just done with one case scenario. Hope you are all there with me. Not exhausted, not bored. No? Yes? Okay. Off late, I think, Rekha left, I think. Now my son is giving boards, CBSE boards. Now I'm also attending online classes with him. There is one guy called Prashant Kirad. I don't know how many of you guys have 10th class or not. he is always asked, how is the Josh meter in between? So I also have to ask, how is the Josh meter? So it's 100%, 80% depending on that. I will cut down my talk or go ahead with my talk, right? So the case scenario 2, here is a male person, Mr. PS, without any significant history. So this is the semen analysis. How is the sample?
Oligo and actinol. And even
Sample.
2 year oligo actinol.
I have a lot of cases to discuss. Fat. Oligo. What is oligospermia? Fat. Number is less. Good. Astheno? Terito? Morphology. What is the normal morphology we are looking for? 4%. So oligo, astheno, terito. Okay. Is this sample good for IUI? Is my next question. It's okay. We all know that it's oligo, astheno, terito.
Total sperm count has to be 5 million. It is this 2 million.
Exactly, very good. See, generally what we see is only 10 million, good to go. It's not that we are not going to do IUI, even though the motility is less, but at least it is helpful to counsel the patient. If the total motile count of the sperm before processing IUI itself is less, you are not going to get better success rates, even though you are washing the sample, doing whatever procedure you are doing in the workshop here, but still the success rates are not very good. So, proper reading of the semen report is very important, right? Okay? So, what are the options? Donor sperm, antioxidants for 6 months, which we have discussed. Then review who will come after 6 months if you give antioxidants, no one. Detailed evaluation, IVF ICSI with self-sperms, right? So severe male factor, if not left untreated, there will be progressive decline in the sperm parameters. So this is one nice interesting study in the urology paper where they have seen that 60 untreated or unintervened samples of oligo, astheno, terito, 24%, this is about 65 patients, where 16 patients with severe oligo developed into azo, 2 patients with moderate became azo, none of the patients with mild oligo developed azosperm. That means severe cases of oats can lead to azospermia in the future. So here comes again the option of fertility preservation. It's very important. As a doctor, even though they want to go ahead or don't want to go ahead, but as a doctor, as a professional, you have to definitely give the option of fertility preservation. And sperm, it is very easy. Egg, there is a lot of process. They have to go for stimulation, pick up, there is that. But sperm, at least they can, even though you are going to try with him for medications, oral or IUIs, at least give them the option. At least tell them the option that this is an option available for you to freeze the sperm, and you have the data here. That in future you may land up with azospermia. You can keep this paper and also tell one more take home point. Right? Fertility preservation. At your level, at the gynec level, if you start motivating the patient, you are doing lot of help to the patients to get pregnancies with their own gametes. No one wants a donor. No one. I will tell the last option as a donor. If nothing is working out with me, touchwood, my patients are very patient with me. They are there for me with years also if they need it. But they understand. As I am discussing with you, like this only I discuss the patient. Tell about 5-10% success rate in IVF cycle. Also patient go with me, which I feel is a blessing for me. But it's about counseling them and giving them proper information. Decision is obviously the patient, but you have to give a proper information. So fertility preservation is something you all need to discuss with the couples if they want to delay their pregnancy for some other reason or they want to try other methods before, just freeze the sperm. That's it. Right? At least male, it is a very easy process which they can go ahead with. Right? So that's how, and as I told you, it's about total motile sperm count is a better indicator for the severity of male factor infertility than the WHO classification, where we are only looking at the count mostly. So motile sperm count is something which is very important parameter which you have to look for. Okay? So as I told, that's about it. No, right? This is about the per cycle pregnancy rates. The counts are 10 to 20 million, it's about 18%. If the count is, as we are taking about the cutoff of 5 million, as Dr. Mansa discussed, the success rates are as low as 2.7%. Right? This is how you go about the pre-wash. This is all about pre-wash. The post-wash motile sperm count they have told is minimum is 1 million actually, but we have not seen pregnancies with post-wash 1 million. The minimum thing which we can look for is 5 million. Post-wash also. Right? So if the total motile sperm count is less than 5 million, it is always better to go ahead with IVF cycles or ICSI cycles which have a better success rates, right? And if you have a low motile or low volume sample, you can always ask for a double ejaculate. Okay, that is one technique which can always consider. You can ask them to, at a gap of half an hour, you can ask them to give one more sample. You can pool the sample and increase at least the count and motility and inseminate. That is something which you can think of as a solution or as an option. Okay, double ejaculate often produces better quality of sperm. There are so many papers which justify it. So, in pooled samples also you can try. So, there is sperm counts are low, max cycles of IUI you can try are. If you ask me, I think 4. 4 is decent. 3 is okay. 3 is very good. Someone is stopping at 3, I really admire. But 4 is decent. 6 is, I feel, it's too much. I've seen some people trying 12 cycles, 10 cycles. Just like a normal routine, but it's not, if it's not working, the best success rates are there in the first 3 cycles. But 4th cycle, I do try in some cases where I feel everything is very good, but still it's not working out. What I do? I do a total recombinant cycle, same like an IVF cycle. But I go with as low as 37.5. I've gone to 25 units also, if the very thin BMI. But I do, my last cycle is always a total rec FSS cycle with as low as 37.5. I'll get only 1 egg with that. Very rarely I get 2 eggs, but the results are very good. Because I get a very good endometrium also when I give a recombinant FSH, right? That's how I put it, right? So my 3, basically case of severe dysmenorrhea, AMH is good, 5 cm endometrioma and right ovary, semen analysis normal. What do you want to do? Yes, counseled. What do you want? You want to go? See, 2 options. Want to go for surgery or not? First question. You want to go for surgery. Okay. Then what do you want to do? Yes, we have done. What are the 2 main complications of endometriosis surgery? Very good. Second, anybody says the second, you are going to get 1 more prize. No. Anybody answering this? 1 more gift from my side. Decreased reserve, everybody is going to tell, I know. No. Who said recurrence? The main important thing which we are going to counsel is about tell them. We only tell them that the egg reserve is going to come down, AMH might come down. Recurrence is something which we need to discuss, right? So that's about it about the endometriotic surgery. See, to operate it, here the image is very good. So we can definitely take a chance for laparoscopy in this patient. And she's just married for 2 years. They won't be definitely ready for IVF, obviously. So it is, image is good, young patient, married for 2 years, 5 centimeters, unilateral endometrioma. Mostly the prognosis will be much better with laparoscopy. You're going to do laparoscopy and offer her IUI. So what is the role? Is there a lot of people? Endometriosis, IVF. Anybody who see endometriosis, mostly they say they land up with IVF. No, it's not like that. They are also, I think ISHRE guidelines are also recently have been come where they have clearly said that in stage 1 and 2 endometriosis, IUI has a very significant role and the results are good with IUI in stage 1 and 2 endometriosis, and also laparoscopy can also be advised in these cases, okay? And we have one nice this thing which has come up, I think you might be, during surgery we have one form, endometriosis fertility index. That's a very good form. You can fill that during the time of surgery. It will give you, guide you which form of treatment you can go later after surgery. Very good, nice form. It tells you about the tubal pathology, tubal findings, how are the tubes, how is the POD, everything. So it gives you a very, I feel very nice. That form is very nice to plan the next course of indications for IUI. Why?
Because of poor quality.
Yes, and another thing is mostly endometriosis is mostly associated with adenomyosis. What is endometriosis? It is a inflammatory condition. Wherever there is inflammation, there is adenomyosis also which has come into play. Again, I somehow gets random things in my brain to discuss. I have given a talk recently in ISAR on what? Probiotics. What they have given, one theory for endometriosis, very interesting I felt, is change in the uterine microbiota. So, if you are not keeping your vaginal and endometrial microbiota, obviously there is an invasion of the pathogens. There is chronic endometritis. This is also one of the reasons for developing endometriosis. That's right, interesting theory. So, when I gave a talk about probiotics, what I understood is probiotics can cure cancer also. What I understood, very important is to have a healthy microbiota, which we all ignore in our own health also. Now, how many of us are having gut problems? Lot of people are having gut issues now. We are not able to eat. Irritable bowel syndrome has increased in incidence. So it's very important to have a healthy gut microbiome. Gut is most in reproduction also. Once I read about microbiota and probiotics, my what laddu futta, that ad will come what that dairy milk, that shards or something. Laddu futta brain mein laddu. That's how my brain blasted, like what, this much is there for microbiota. Why we are all talking about microbiota? Now we have, I think, like how we are doing receptivity array, we are doing microbiota array now. We are studying about the uterine microbiome. In cases of recurrent implantation failure, we are studying about uterine microbiome and then replacing them with that probiotics to increase the implantation. There is a new research which is happening, which I felt very interesting. Probably if I have a chance, I asked my people to do what? In cement to see the microbiota. I tell so many things, the thing should come from that. So I told them there is a sperm with lactobacilli dominant is more fertile when compared to non-lactobacilli. So we can do a nice study about it to see the male, because we get a lot of sperm samples in and there. So to study it, I told my team, but I don't know how far they have come for that. So that's one interesting study I want to do in future to see about the microbiota and male fertility, male sperm. So where I went to microbiota, I don't know. Endometriosis, reason. So that is one thing. So gut all of us to keep our guts very safe. It's for us also. Gut plays a very important role. Inflammation plays a very important role. Cancer we all know, because vaginal microbiota damage, HPV infection, cervical cancer, we're doing so many programs about awareness of cervical cancer. So it's very important to maintain that vaginal microflora, and it's the important thing, right? So the human reproduction, they do not recommend IUI in endometriosis. There are so many agreements and disagreements, but definitely stage 1 and 2 in endometriosis, you can definitely try IUI. So then on the day of IUI, husband collected sperm, previous semen analysis is normal in this patient, Jyoti ma'am, again. Today we got only 4 to 5 motile sperms. How to deal this situation? Anybody? How to deal? Normal analysis. I think give the mic to our young embryologist there. Not the senior, youngs. Jahnavi, where are you? Okay. So, we are planning IUI. I have sent this person for seven. I have sent the permission to collect the sample. Jahnavi, take the mic. Okay. So, I have sent you for IUI. Patient came to you. His previous report, you have only analyzed it. You have done the semen analysis. When the patient came, normal. He has given the sample today, 4 to 5 motile sperms. How to deal in this situation?
Only 4 days cells.
Huh?
Only 4 to 5 months.
Yes.
You can collect multiple samples.
Multiple. How many? How many he will give? A person. What do you think? Giving a sample is such a easy thing. Give multiple. How many? You give 10 samples. We will collect and pool the sample and do. It's not easy. Okay. But the thing is correct. You can ask for one more sample. That the intention is correct, but not multiple. Okay. So, what might have happened? Yes. Most common thing is spillage, and patient doesn't tell you that. I will definitely ask if I get a low volume in your analysis also. Once you get a normal sperm count, and if you see the volume 0.5 ml, I will definitely ask the patient whether you have spilled the sample. Most common thing. They don't understand how to collect the sample first. So first they spill and they collect the remaining last portion. So that's how it happens. So it's very important that they might have spilled the sample. So basically, the first report might not be correct. It might be that one reason. You should always think about it. You should think all permutations and combinations. If my brain works 10 times, I will think 10 options. This might have happened, this might have happened, and then come to a conclusion. That's how my brain works when I deal a situation. So your lab might not have given a proper report, or embryology variation will be there. Now we are all came to A-based analysis. Now we are not dependent on the person as such now. I don't know, future now they are saying robo-XCs. So robo will do the XC. You install a robo and that robo will do all the XC. So that's the future of the IVF lab, right? You have heard about robo-XC? Right? Robots doing ICSI now, robots are doing laparoscopies. Why not ICSI? It is even much easier than doing laparoscopy, right? So that's how it is. So it can be a intra-individual variability. Might be the patient might have suffered with some infections, right? Might be some new insult to spermatogenesis. So you have to think these many things when you're getting one sample report. Or inadequate testicular stimulation, or it can be some spillage as we have discussed, right? So it's very important to look for this, right? Then as she mentioned, you can ask for one more sample. Ask for double ejaculate. We can't ask multiple because it's a very exhausting thing to give a sample. It's not a pleasure thing to give a sample in a lab. For a man, we have to understand that. So it can be a double ejaculate, right? The solution is taking one more sample. So So I'm not going to theory aspect of this. You can all read it. The sperm count is less. You can go for ICSI and all. So I'm not going to detail. Anyhow, they are going to discuss about the sperm preparation process. My team will be discussing it and make you do hands-on today. I feel all of you should try hands-on IUI. Don't just listen to the theory and go. It should be your own experience of how you can prepare a sample. Then you really understand. If your technician is preparing also, you know what's going wrong and why your cycles are not working. You're not getting proper IUI success rate. You should know what's going on wrong, right? If you know the process, then only you will know. I advise all of you to please stay back for the hands-on workshop. So it depends on the method. Mostly we use this density gradient. I'm not going into the laboratory aspect of it. Now we have the microfluids as well to get a better sperm sample. Insemination, we all know I do only single IUI. Very rarely I do double IUI. It's mostly I give trigger 36 hours later we do an IUI. If you are doing double IUI, it is 24 hours and 48 hours. The next question, most important question is whether I have to do IUI if there is ovulation only is the question. That's what we are interested in. We are not interested in this. We all know this. Right? So yes or no? Yes? You confirm ovulation and do? If there is no ovulation, patient has come to you. Will you go ahead with IUI or not? Simple. Yes. And again, embryology team. Processed sperm can survive in the vaginal tract for how much year? Actually, processed sperm can survive in the vaginal tract for only 24 hours. Another take home. It's not that intercourse, when you have normal intercourse, that is a different scenario. But once you are processing the sperm, it's not going to have that much capacity. It's only for 24 hours, but that's going to cover that period. But I want to tell you that processed sperm is different from a normal intercourse sperm. Right? So that's what I want to tell. So where am I? Yes. So you can go ahead with insemination even though there is no ovulation, but it is always good practice to confirm ovulation and do. I do confirm ovulation and do. Sometimes I repeat the trigger.
One query actually. Before doing IUI, if you do the BVS scan, I heard the gel will contain the spermicide.
We won't keep on the above, right? We only keep in below the condom.
Okay, not above.
See, we are not keeping above.
Okay.
So, obviously you need that gel for lubrication for the resolution to come, but you are not keeping above. Generally what you do, you keep the gel, keep the condom, again keep the gel on the, so you are not going to use the above gel.
Okay.
You can use the probe cover, no?
No, in the probe cover you keep, sometimes you keep above also. Generally we don't use that. You use, no, if it is very tight, you can use normal saline for the easy penetration.
So if it is not ruptured after 36 hours, after how many hours will you repeat the scan for the confirmation of the ovulation?
See, basically as I told you, you can go ahead with IUI first thing. But what I do in my practice, I give a agonist trigger in those cases. There I feel agonist works. Because why? Agonist gives a flare effect. The terminology is flare effect. So there is a sudden increase in the FSH and LH. So ovulation mostly happens with agonist. If I am giving HCG, there is no ovulation. Generally I give agonist, wait them in the clinic for 2 hours. I just confirm whether they have ovulated or not and then do IUI. Or if they have not ovulated, I do the IUI, send them. And ask them to have normal intercourse. One more important take home point is to have intercourse on the day of IUI. Basically, to be frank, increases the success rates of IUI. Generally what they think is IUI they have to go for bed rest. A lot of patients think that we have done a big procedure and they shouldn't have. But intercourse on the day of IUI improves the success rates of IUI. But if I feel that there is no ovulation and I have done IUI, I definitely ask them to try to have a normal intercourse if the sperm is very good. It's not going to work if the sperm is very bad, that's fine. So that's how it is. Or You can also call for a double IUI. Next day also you can ask them and inseminate, but I don't do that in my practice. But practically it makes sense to confirm ovulation. But if the patient is very near, I definitely ask them to come next day to confirm at least ovulation. See, for us to understand, see if this cycle is not going to work. What you're going to next cycle is, I always plan the next cycle. That's how my brain works. I don't know. I'm for the next cycle. If this is not working out, what's my plan for the next cycle? How I am prepared for the next cycle is how my system works. So the fourth is like PCO not respond to letrozole and CC, underwent LOD, tubes patent, partner semen normal, request for IUI. As I told you, this is how I go with my total recombinant cycle, but here it is a taken case from some other place, but as I go with as low as 37.5. As I told you, 75 I never start with. You go because recombinant you have a advantage of taking as low as 37.5 units. So you won't go into hyperstimulation if you go with total recombinant cycles also. Hardly you will get one follicle, which is very good. The second thing is the most another practical question. 16 mm, you have not given trigger, follicle rupture. Will you do IUI or not? We can do when you are giving a recombinant cycle. There is a maturity as early as 15-16 mm. There is no need to cancel the cycle after giving so much of gonadotropins. You can go ahead with IUI. Trigger is definitely not a must thing, but if you are triggering, you can plan properly. Okay. So sometimes if I am getting a single follicle not good, we convert the IVF cycle to IUI also. These situations can also, very poor ovarian reserve patients, it can happen. Prevention of premature ovulation. We all know antagonist is a new kid on the block where we are adding antagonist. How do you diagnose premature ovarian? Premature LH surge is the question. It's not about the solution. We know the solution. How to identify premature LH surge? You won't do LH kits for everybody, right? Yeah, you do. One of the method is LH kits. How do you suspect or good. Generally, if you are seeing a follicle, 14 mm, 15 mm, you call them for our next day scan or alternative. You are not seeing the follicle. That's how you identify, right? Rupture of the follicle before attaining maturity. Not trigger, sometimes it may naturally ovulate also. That's how it is, right? Before attaining maturity only the follicle is rupturing. The name itself premature. The follicle is not mature enough. Still it has ovulated. That is premature LH surge. That is very important. Why? Because it is repeating sometimes. Cycles. In these cases there is a role of antagonist. We do have a role of antagonist in IUI cycles. These are the cases where you can add antagonists. Mostly this happens in elderly age women. Mostly you see this type of scenarios in advanced maternal age, right? So basically, but there are so many studies which say that antagonist is useful, not useful. But for me in my practice, premature LH surge is identified. You can give antagonist, and advanced maternal age also you can add antagonist to improve your success rates in your IVF cycles. Okay. So the next is like Mrs. S undergoing IUI for unexplained subfertility, satisfactory stimulation response, no significant medical. So catheters. What catheters do you want to use in your IUIs? See, basically any catheter doesn't affect your success rates in IUI cycles. You can use what type of catheter you are comfortable with. That doesn't matter. Catheter should not be negotiated. That means it shouldn't be a difficult insemination. That is the motto. If it is a difficult insemination, how to deal with it? Mostly 20% of the cases can be difficult. You can use hard catheter in this. You shouldn't get ultimately blood at the tip of the catheter. Shouldn't be there. So if it is there, what are the interventions you can do? One is ultrasound guided. The most important take home point is ultrasound guided. You have a difficult insemination, do it under ultrasound guidance. Most important thing. Okay, and also you can give slight traction on the cervix. It doesn't hamper your success rates. But don't poke and then do. If you're feeling that the negotiation is difficult or the catheter is, you're not able to negotiate it, you can still hold with the Alice. But don't try multiple attempts and then hold Alice. Then it will be unbearable for the woman. So just don't take the decision slightly early. If you use tinaculum also, the results doesn't hamper. Ultrasound is best to do with IUI. So this is how you do ultrasound guidance. If you have a difficulty, you can do mock. Obviously, hysteroscopy is the option if you have a very severe cervical stenosis. This is very nice, interesting paper about seasons and IUI success rates, where Spring group had highest success rates, which I felt very interesting. And low AMH, one question, will you do IUI or not? Yes, you can do. But the most important thing which you look for is age. Young age, low AMH, yes, you can do IUI. Older age, low AMH, no IUI. Right? So quality control of your lab is also very important. You have to look for the QC, QF, the labs are very, very important, which I am not going to do. It's a very big chapter on itself. So the key to success of your IUI is check the ovarian reserve of the patient, tubal patency check, sperm analysis, optimize your ovarian stimulation, proper semen preparation, catheter, ultrasound guided, plan single or double, slow release of sperm, see that there is no backflow, and this is how you get good results in selection of patient is very important. Young, optimal ovarian reserve, mild oligoastheno, patent tubes, no or minimal pelvic pathology. Refer to an IVF specialist if the age is more than 35. That's what we learned today. Reduce ovarian reserve, young age, low AMH, you can try. Older age, low AMH, don't try. 4 failed IVFs, what we have learned to do is 4 cycles today. Severe male factor, no IUI. Extensive endometriosis, we have learned, no IUI. And wherever you need a cryopreservation of the sperms. So it's very important to carefully select the couples. Maximum is for me 3 to 4 cycles. As I told you, reproductive endocrinology. All of you should go back and read Spiroff. Very, very important. Especially if there are PGs here, please read Spiroff. It's very good. Physiology of control ovarian stimulation. Use of gonadotropin in IUI, but avoid multiple pregnancies and OHSs. Well-timed single IUI is the best. Avoid endometrial injury, strict sperm cutoffs for IUI. If all these are adhered to, we are able to unlock the signs of IUI success today.
Where I have started my career as an embryologist at Karimnagar. And thank you all for being here. And thanks for your patience, for listening us. And my topic is, actually we are scheduled to maximize the sperm quality and how to prepare the sperm for a better the sperm. My concept is only the sperm. So sperm is a Greek word. Actually it's derived from a Greek word. The mean sperm means a seed actually. So that's what I'm going to explain you. Actually, if we won't select a good seed, we won't get a good cultivation and good outcome, right? If you plant a neem seed and you can't expect a mango tree, right? So to have a better outcome, if you want a better pregnancy outcome, you should have a better sperm. So that's the thing. My concept is a seed for the next generations. And here, as per a recent paper, which is published very recent paper, which are like global fertility in 204 countries and territories from 1950 to 2021. So they have come up with a conclusion that accurate assessment of current and future fertility, including overall trends in changing population, age, structure across countries and regions, are essential to help plan for the profound social, economic, environmental, and geographical challenges that these changes will bring up. And the GBD, like a global burden of diseases, injuries, and risk factor study, 2021 produced up-to-date and comprehensive geographic assessments on key fertility indicators at global, regional, and national levels from 1950 to 2021. And fertility is declining globally with rates in more than half of all countries and territories in 2021 below replacement level. Like trend since 2000 shows considerable heterogeneity in the steepness of declines, and only a small number of countries experienced even a slight fertility rebound after their lowest observed rate with none reaching replacement level. And additionally, the distribution of live birth rates across the globe is shifting with a greater proportion occurring in the lowest income countries. Future fertility rates will continue to decline worldwide and will remain low even under successful implementation of pro-natal policies. So why I'm discussing about this is, see, why nowadays we have come deletion of Y chromosomes, right? So why sperm preparation is required actually? So why it's coming down? Why the motility is coming down? Why the morphology is coming down? Why the count is coming down? So we have to assess on this, and we are going to work on that actually. And to do that, so I have chosen this topic actually, the sperm. And as per the WHO, World Health Organization classification of infertility, it's the basic things. As we all know, infertility affects millions of people and has an impact on their families and communities. And estimates suggest that approximately 1 in every 6 people of reproductive age worldwide experience infertility in their lifetime. And in the male reproductive system, infertility is most commonly caused by problems in the ejection of semen, absence or low sperm count, abnormal shape like a motility, and problems in the morphology also. And in the females, as we all know, infertility may be caused by the range of abnormalities in the ovaries, uterus, fallopian tubes, and endocrine systems, among others. And as infertility can be a primary or secondary, and equal and equitable access to fertility care remains a challenge in most of the countries, particularly in low and middle income countries. And fertility care is rarely prioritized in national universal health coverage benefit packages. And this is an overview, like infertility is a disease of the male or female reproductive system, defined by a failure to achieve pregnancy after 12 months or more of regular sexual intercourse based on their age, like a woman with 35 years, below 35 years of 1 year, and above 35 years of 6 months unprotected sexual intercourse. And infertility may be due to male or female or unexplained factors, and that some causes of infertility are preventable. And as we all know, treatments are available like IVF and other medical assisted treatments. And what causes infertility? Actually, infertility may be caused by a number of different factors in either the male or female reproductive system. However, in sometimes not possible to explain the cause of infertility. Coming to female reproductive system, as we all know, tubal disorders such as fallopian tubes, uterine disorders like inflammatory in the nature as endometriosis, congenital in nature like a septate uterus, and benign in nature like such as fibroids, and disorders of ovaries such as PCOS and other follicular disorders, and disorders of the endocrine system causing imbalance of reproductive hormones. And the relative importance of these causes of female infertility may differ from country to country. For example, due to difference in the backgrounds of prevalence in STI or different age of population study. And coming to male reproductive system, obstruction of the reproductive tract causing dysfunctionalities in the ejection of semen, hormonal disorders leading to abnormalities in the hormones produced by the pituitary gland, hypothalamus, and testicles, hormones such as testosterone regular sperm production, and testicular failure to produce the sperm, abnormal sperm function and quality, like morphology and motility, and lifestyle factors such as smoking, excessive alcohol intake, and obesity can affect fertility. In addition, exposure to environmental pollutants, toxins can be directly toxic to gametes like eggs and sperms, resulting in the decreased number of poor quality. Now we are going to discuss about the lifestyle factors and environmental factors affect the fertility also. And why addressing infertility is so important. Infertility has significant negative social impacts on the lives of infertile couple, and particularly the women. And WHO frequently who frequently experience violence, diverse social stigma, emotional stress, depression, anxiety, and low self-esteem. Men and women socially pressure to prove their fertility because of a high social value of childbearing, and addressing the challenges like availability, access, and quality of interventions to address infertility remain a challenge in most of the countries. And diagnosis and treatment of infertility is often not prioritized in national population and development policies, and reproductive health strategies, and are rarely covered through public health financing. And lack of trained personnel and the necessary equipment and infrastructure and the currently high cost of treatment medicines are major barriers even for countries that are actively addressing the needs of people with infertility. And well, assisted reproductive technologies has been available for more than 3 decades, with millions of children born worldwide from ART interventions like IVF. These technologies are still largely unavailable, inaccessible, and unaffordable in many parts of the world, like low middle east income countries. And as per World Health Organization, WHO recognizes that the provision of high quality services for family planning, including fertility care services, is one of the core elements of reproductive health. And recognizing the importance and impact of infertility on people's quality of life and well-being, WHO is committed to addressing infertility and fertility care. See, this is the latest edition of WHO manual, which is 6th edition, which we use this as a Bible, Quran, or Bhagavad Gita in the Andrology lab, whatever the parameters given as per the World Health Organization. So, which is taken from the 95th percentile of the group, a group of scientists gathering the data survey globally and giving the 95th percentile of the values, reference values. We follow these reference values and go accordingly to the reporting and the treatment for the male fertility. And developing guidelines on the prevention, diagnosis, and treatment of male and female infertility. Continually revising and updating other normative products, including the World Health Organization Laboratory Manual for the examination of processing human semen. And this is again a routine thing like a male infertility as per WHO defines the male infertility as the inability of a man to impregnate a female woman after a year of a regular unprotected sexual intercourse. And the sperm, undoubtedly, it's a very important thing. The male gamete, the spermatozoa, and the most motile cell in the human body, also called as a glorified lysosome, when morphologically normal, post-activation traveling at a speed of more than 25 micrometer per second at 37 degrees Celsius, having ideal progressive motility and linearity, is capable of cortical reaction with an mTOOCI, and post-decondensation result in an ideal zygote and the conception. And finally, the sperm is responsible for the determination of the sex of the child. Evaluation of male fertility, semen analysis as the basic investigation, like semen analysis is the basic and single most important test for evaluating male fertility. It involves the examination of quality and quantity of the seminal and sperm parameter. It can be done either manually or using CASA. And here are the WHO 6th edition parameters compared to 5th edition. Now we are going with the 6th edition, like a semen volume more than 1.5 ml, semen concentration more than or equal to 16 million per ml, total sperm number it will be more than or equal to 39 million per ejaculate. You have to point out this actually, per ml and per ejaculation. There is a difference. And total motility is more than or equal to 42%, whereas 30% should be a progressive motility and 1% will be non-progressive, and among that 20% will be immotals. Vitality with a more than or equal to 54%. Vitality is to know in the cases of azoospermia patients, vitality test we do whether the sperm is live or dead to do. Based on this, we'll go with this comes under the functional test. So normal forms should be more than or equal to 4%. And leukocytes like WBC should not be more than 3 to 4, and as per 1 to 2 will be acceptable. And coming to sperm motility assessment, there are 4 grades type A, B, C, D. A will be the progressive motility, which where the sperm moves rapidly. And coming to B, which is a non-progressive motility, type C will be the static, where the sperm will be rotating here and there, but it should not move. Type D will be the immotile. And classification of sperm morphology. Here, whenever you observe a slide under a microscope, first you have to separate, identify that what is sperm, what is WBC, what is sperm, what is this, WBC, and what are the germ cells, and we have to separate that actually. Based on that, we have to do the calculation. Whatever you observe under the microscope, all won't be the semen, or all won't be the sperm. Whenever you are able to identify, whenever you are able to differentiate the sperm with other cells like a germinal cells, epithelial cells, RBCs, WBCs, whatever, then based on that, you have to start assessing their morphology from the tail to the head, not from the head to the tail. Got it? Then you have to go with the tail and the midpiece and the cytoplasmic droplets, and you have to go with the head with the acrosome region, where the head containing vacuoles, large vacuoles, or small vacuoles, and the area of the acrosome coverage and the shape of the head, either it's, whether it's a round or pyriform and whatever, pinhead or whatever it is. Based on that, each and everything will be considered under the morphology. If the tail is not normal, if the midpiece is not as per the criteria, and the head is not in the oval shape, anything will be considered as an abnormality. And this is the normal sperm structure, which contains head and tail. Tail has 3 pieces like a midpiece, principal piece, and terminal piece. And we also said head plays a key role, which contains the DNA and the nucleus, which has the carrying our genetic material from the generations to the generations. So head plays a key role. And coming to the proximal centriole, you can see a small dot here, which is a connecting point between the head and midpiece to the sperm. And as routinely, midpiece, which contains mitochondria, we all know the powerhouse of the cell, which is the source of the sperm to produce the energy. And the sperm, usually it's a filament, which helps the sperm to move forward in the flagellar movement. And this is how the normal sperm looks under a microscope by doing diffuse staining technique. And we have got the slides also. If you are interested, I'll show you the slides also, which are prepared slides also I have brought to you. This is what the normal sperms looks like. Here you can see, you can clearly assess the acrosome region, which is covered clearly, acrosome and separated acrosome and a cap. Here. And here are the normal parameters what we have to consider, and abnormal things with the head, midpiece, tail, and cytoplasmic droplets. While coming to head, the head should be smooth, regularly counted, and generally oval in shape. There should be a well-defined acrosomal region comprising 40 to 70% of the head area. And the acrosomal region should contain no large vacuoles and not more than 2 small vacuoles, and which should not occupy more than 1/5 of the sperm head. And the post-acrosomal region should not contain any vacuoles. And if anything apart from this, acrosome less than 40% or larger than 70% of the normal head area will be the abnormal. And length, if it is also a abnormal thing. Vacuoles consisting more than 1/5 of the head area located in the post-acrosomal region area, or double heads also considered as a abnormal sperm. And coming to midpiece, it should be a slender, regular, and about the same length of the sperm head. Midpiece should be equal to the sperm head. The major axis of the midpiece should be aligned with the major axis of the sperm head. If the head is irregular shape or thick or thin head, asymmetrical or angle or sharply bent will be considered as an abnormal thing. And coming to tail, the principal piece should have a uniform calibre along its length, be thinner than the midpiece and approximately 45 micron. and if the head has double head or short, irregular, or multiple tails, will be the abnormal thing. And coming to the reporting, as we all discussed now, I'm briefing about it. Aspermia, like no ejaculate in the sperm present in the semen, and hypospermia, the reduction in the volume, whatever we have discussed, more than or equal to for 1.4 ml, and hyperspermia, there is an increase in the volume like more than 3 to 4 ml. And azoospermia, no sperm found in the semen and any absence of the sperm. And oligospermia, the sperm count is less than the expected, like less than 16 million. Polyspermia is more than 100 million, it's the polyspermia. And pyospermia is the presence of WBC in the sperm, low sperm motility. Oligoasthenospermia with a combination of low count and low motility. And teratospermia, low percentage of normal sperms. And necrospermia, if all the sperms are dead. And this is the comprehensive assessment of the sperm morphology. And the major important thing is sperm DNA fragmentation. So, DNA fragmentation is the separation of breakage of DNA strands into pieces, like a single stranded breakage or double stranded breakage. Like you can see an intact DNA here, and coming to single strand breakage and the double strand breakage, it comes to the fragmented DNA. So, what are the indications for DFI? Why we have to do DFI? So, if a couple with unexplained infertility or recurrent early pregnancy loss, poor embryo formation during IVF, multiple IVF cycles, multiple failed IUI cycles, chronic smoking with a male partner and advanced age, varicocele or varicocelectomy surgeries, poor semen parameter, exposure to harmful substances such as smoking, radiation, chemicals, or air pollution. And both single strand breakage is easy to repair and better prognosis. Double strand breakage unrepaired, gross alterations to chromosomal structure. The double strand breakage more serious and deleterious impact on developmental of pregnancy. DNA repair mechanism does occur in developing sperm, but absent in mature spermatozoa, mainly due to termination of transcription and translation process post spermatogenesis. However, oocyte has been shown to repair sperm DNA damage to sperm some extent, especially single strand breakage. The biological effect of abnormal sperm chromatin structure depends on the types of sperm chromatin damage, like single strand breakage or double strand breakage, and capacity of oocyte to repair it. The causes of sperm DNA fragmentation mainly classified into two categories, like primary testicular events and extratesticular event. Like primary testicular events comes like abnormal germ cells, like apoptosis and exposure to gonadotoxins, advanced maternal age and sperm chromatin packaging abnormalities, and high level of ROS. While coming to extratesticular factors like smoking, radiation, chemotherapy, genital tract infections, varicocele, diabetes, and testicular hypothermia. And the integrity of sperm DNA can be evaluated by these assays like ACS, sperm chromatin structural assay, tunnel assay, comet assay, and ACD. As we all routinely doing ACD, sperm chromatin dispersion assay, where the sperm DNA like acid denaturation and lysis solution will be added, and the chromatin decondensation. The forms halo around sperm head and in agarose gel indicates DNA intact. Absence of halo indicates DNA damage. Here is the halo dispersion pattern. Big and medium size halo considered as a normal and intact DNA. Small and no halo considered as a abnormal or fragmented DNA. The result of sperm DNA damage is expressed as DNA fragmentation index. The cutoff value is 30%. More than 30% indicates sample with more damaged DNA spermatozoa, and less than 30% indicates sperm with less damaged spermatozoa. Here you can see higher DFI, higher percentage of sperm contains fragmented DNA. DFI more than 30% abnormal or more fragmented. DFI less than 30%, like 25 to 30% will be considered normal or less fragmented. And what causes of male infertility? Here are a few causes like primary gonadal disorders, like we all know Klinefelter syndrome, Y chromosome deletions, single gene mutations, and polymorphism. example involving the androgen, estrogen, and FSH receptors, and cryptorchidal. This is what actually happens during the puberty, like undescended testis, like varicocele infections, and radiation environmental gonadotropins, like heat, smoking, metals, organic solvents, and pesticides. Chronic illness like renal insufficiency, cirrhosis, cancer, sickle cell diseases, amyloidosis, and vasculitis, celiac diseases. And here are the lifestyle factors and disorders of sperm transportation coming as a epididymal obstruction or dysfunction, congenital bilateral absence of vas differences related to CFTR mutations, and infections obstructing the vas differences, vasectomy, and Young syndrome ejaculated dysfunction like spinal cord diseases, autonomous dysfunctions. And what are the effects of lifestyle on male fertility? The population explosion and infertility are the two major problems of human reproduction. As we discussed, according to the United Nations, the most populated countries in 2050 are expected to be India, because recent survey, I don't know how many of you have gone through this. Indian population has grown to 1.34 billions now, and expected to be India, China, Nigeria, and United States, Pakistan, Indonesia, Brazil, Democratic Republic of Congo, and Ethiopia. And the world's population is expected to reach 9.7 billion by 2050. And like one more paper from a survey we got that as many as 180 million couple may be affected by infertility by 2050. India is expected to overcome China as the world's most populated country by 2027, and the proportion of older people will increase, with 1 in 6 people over 65 by 2050. Global fertility is projected to fall from 2.3 children per woman in 2021 to 2.1 in 2050. And the manifestations of male fertility, like sexual problems, abnormal semen parameters, lifestyle factors. Coming to sexual problems like erectile dysfunction, loss of libido, and abnormal semen parameters like oligospermia, asthenospermia, teratospermia, and increased DFI. Lifestyle factors are amended habits and ways of life that can greatly influence overall health and well-being, including fertility. As we all know, age, BMI, nutrition, occupation, smoking, alcohol, recreational drugs, caffeine, and sports. So, as advanced paternal age, as we learned in our previous session, assumption that men can reproduce into advanced age is totally untrue. After 40 years, the reproductive potential of men drops sharply, increase in structural abnormalities and high DNA fragmentation. And the another main thing is obesity, defined as BMI of more than 30 kg per metric unit, is a disease approaching pandemic proportions, affecting more than 1.9 billion adults over the age of 18 years worldwide. So BMI ranges 20 to 25 will be the normal, 25 to 30 the overweight, and 30 to 35 will be the obese. And how BMI affects the fertility. So BMI as the increased adipocytes, like physical, seminal, and hormonal effects. While coming to physical, erectile dysfunction, scrotal temperature, increased scrotal temperature, and sleep apnea disrupts nocturnal rise in testosterone. And coming to if the physical disturbance is there, it will automatically impact on the seminal issues, like seminal values, like oligospermia, azoospermia, or increased DFI, and low semen volume. And also impact on the hormonal, high increased estrogen levels, decreased testosterone, high insulin, and high leptin. And how it impacts on the male obesity, like it impacts on the sperm, embryo, and offspring, like a reduced motility, lower sperm count, reduced morphology, increased ROS, increased DNA, impaired mitochondria, and coming to embryo, reduced fertilization and reduced formulation, and impaired cell-to-cell contacts, reduced cell membrane, impaired mitochondrial function, Coming to offsprings, small at birth with catch-up grown glucose and insulin intolerance of up to 2 generations. And coming to diet and nutrition, as now pizza, burgers, sandwiches, it's like a luxury. How if you are good at how rich you are if you are having pizza, burger, and all. So if you have salads, fruits, fresh vegetables, it won't show your luxuriness nowadays, right? So whenever you go out, you like to have a pizza, burger, sandwich, so French fries. This is what we accept. This is what we give for our kids, children nowadays. So no, better go with the natural. A healthy diet with rich in fruits, vegetables, fish, nuts, whole grains, and low-fat dairies products can positively impact sperm quality by providing essential nutrients like vitamin C, E, and B complex, zinc, selenium, and omega-3 fatty acids, which are crucial for sperm production, motility, and morphology. And beyond individual nutrients, overall dietary patterns can also influence sperm production and fertility. And we all know this Mediterranean diet and Western diet. Coming to Mediterranean diet, which is characterized by high intake of fruits, vegetables, whole grains, ligaments, fish, and healthy fats, mainly from olive oil, has been associated with improved sperm quality. And the abundance of antioxidants, omega-3 fatty acids, and polyphenols in this diet may contribute to the reduced oxidative stress and inflammation, leading to better sperm production and quality. Coming to Western diet, typically high processed foods, red meat, refined carbohydrates, and saturated fats has been linked to poor sperm quality and reduced fertility. The Western diet's high content of trans fats and refined sugars is thought to promote oxidative stress and inflammation, contributing to reduced sperm concentration and motility. And smoking. Nowadays, it's very whoever with a graduation or anything. So if batch like a 4 members, 5 members gather at a cave or a coffee shop, if you won't smoke, you'll be avoided from the batch. You're eliminated from the batch. This is what the trend in the colleges now. So actually, I had a video also, but we are lack of time. I can't play that. So traditional smoking has been extensively studied for its detrimental effects on sperm health and male fertility, which includes decreased sperm count, impaired sperm motility, abnormal sperm morphology, DNA damage, hormonal imbalances, increased risk of erectile dysfunction. The decline in semen quality was found to be more marked in heavy smokers like more than 20 cigarettes per day, moderate from 10 to 20 cigarettes per day, and compared to mild smokers 1 to 10 cigarettes per day. It's also actually not acceptable, and the remedy is quit smoking. Alcohol. So without smoke and without alcohol, no college days, right? So alcohol consumption is a widespread social activity with a significant implications of health. In men, excessive alcohol intake have been linked to a range of adverse effects on sperm functions and overall fertility. Hormonal imbalance, like alcohol disrupts the endocrine system, affecting the hypothalamic pituitary gland axis, the pituitary gonadal axis, thereby reducing testosterone levels by impairing the function of Leydig cells in the testis, leading to decreased sperm production and quality. And testicular damage, chronic alcohol use can lead to direct toxicity in the testis, result in testicular atrophy, reduced testicular volume, and impaired spermatogenesis, leading to a lower sperm count and decreased fertility. And oxidative stress, alcohol metabolism in the body leads to the production of ROS, which can cause oxidative stress. Oxidative stress damage sperm DNA, lipids, and proteins comprising sperm integrity and function. This can lead to reduced sperm motility and abnormal morphology, thereby impairing fertility potential. And one more thing, recreational drugs. So cannabis are commonly preferred to as marijuana. I don't know how you are aware of it, but recently we have gone through a case. So it's a very critical thing actually to evaluate them and to counsel them psychologically. Heroin and opioid narcotic in the most abused illegal drugs globally and has predominantly male users. Marijuana smoking more than once weekly causes lower sperm concentration, lower total sperm, and long term, like more than or equal to 5 years, cocaine, heroin, opioid, narcotics users had lower sperm concentration, motility, increase in abnormal sperm morphology, and AS, anabolic androgenic steroids. Anabolic refers to the tissue building, mainly muscles, called androgenic refers to the group of sex hormones called androgens. Like mainly prescribe these drugs to treat low testosterone, male hypogonadism. Some athletes, bodybuilders, and other misuse these drugs in attempt to enhance performance and or improve their physical appearance. And how it affects on fertility, like testicular atrophy, transient azoospermia, loss of libido, and erectile dysfunction. And one more thing, which is a favorite to everyone and most of us here, like caffeine. Few cups of coffee, tea, or caffeinated cola have no impact on the male fertility, but caffeine in excessive amounts, such as 4 to 6 cups of coffee per day, or total intake exceeds 800 milligrams per day, can lower sperm count and quality. And occupational hazards, chemical exposure. Certain chemicals commonly found in workplaces have a detrimental effect on the male fertility. Prolonged exposure and inhalation to solvents, heavy metals, lead, mercury, etc., pesticides, drugs in the pharmaceutical companies, and industrial chemicals like benzene and toluene can negatively impact sperm production, quality, and function. And heat and radiation. Excessive heat and radiation can disrupt normal sperm production. Occupations that involve working in hot environments such as steel plants, furnaces, bakeries, and welding workers can increase scrotal temperatures, leading to reduced sperm quality. Similarly, individuals who are working with radiation, such as radiologists or nuclear plant workers, may experience decreased sperm production and quality. And one more thing, physical strain. Jobs that involve prolonged sitting, driving, and or heavy metal lifting can lead to increased scrotal temperature and decreased sperm quality. Occupations such as truck drivers, long haul flights, or jobs that require prolonged sitting, like software professionals, can negatively impact male fertility. And vibrations, frequent exposure to vibrations such as those experienced with heavy machinery like proclaimers, JCBs, operators or rock drillers can have negative impact on sperm health. Research suggests that long-term exposure to vibrations can cause sperm abnormalities and reduce fertility potential. One more thing, mobile phones. Without mobile, we can't, right? So, mobile phones have become indispensable parts of our lives. However, cell phones do emit low-level radio frequency electromagnetic fields, or RF EMF is a radiation. If those cell phones are emitted at maximum power, surrounding area can be heated up to 0.5 degrees Celsius, which impact on sperm count and viability. It is recommended to keep mobile away from the scrotum and not to keep in shirt or pant pockets. So you can see some of our uncles, like old people, they'll be carrying mobile in the side, they'll be having a pouch to the belt, right? So we think that, see how he's wearing a mobile out of the pocket. So they know, they're aware of it actually. If they tell, we won't listen, right? And laptops. Prolonged laptop usage on the labs can potentially negatively affect sperm parameters, primarily due to the heat generated by the device, which can rise the temperature of the scrotum, impacting sperm quality and motility. And sports, like genital injuries. Most of the common mechanism of injury in athletics is from direct impact from the fall, kicks, ball contact, and impact on the vehicles or bicycle, leading to testicular trauma or torsions. Testicular injuries should be treated without delay. Men should take extreme care during sports in which testes are not properly protected. And this is one more paper, very interesting, how do lifestyle and environmental factors influence the sperm epigenome, effect on sperm fertilizing ability, embryo development, and offspring health. They say that recent studies support the influence of paternal lifestyle and diet before conception on the health of the offspring via epigenetic inheritance through sperm DNA methylation, histone modification, and small non-coding RNA expression and regulation. Paternal diet and obesity are associated with a greater risk of metabolic dysfunction in offspring via epigenetic alterations in the sperm. And DNA methylation is correlated with the alterations in sperm quality and the ability to fertilize oocyte. Paternal exposure to toxic endocrine disruption is also linked to the transgenerational transmission of increased predisposition to disease. And this is one more very important thing, like effect of environment on male fertility. The modern man is constantly exposed to a variety of toxic chemicals, primarily due to modernization of lifestyle. You can see the food we eat, the water we drink, the air we breathe, and the environment we live in the are contaminated with variety of toxic xenobiotics. So this is what the cities, metropolitans, what we are living, we are choosing to live, right? And the sources of pollution, like air, water, soil, plastics. Whatever we are having, whatever we are living, whatever we are taking, whatever we are eating, completely polluted. The main thing is air pollution. Air pollution is significant global health concern affecting almost 2.4 billion people, causing over 6.4 million deaths annually. Like so carbon monoxide, nitrogen dioxide, sulfur oxide, ozone, and particulate matter. So I am not going very deep into this. Now, as Dr. Poornima asked, how liquid nitrogen is prepared. So it is prepared through air. The vacuum, the collected from the air, and the separation of oxygen, nitrogen are separated and they are released into the air again. Okay, so by that way, the air is fully contaminated. We are inhaling the contaminated, polluted air through these things. So I am not going to discuss about the particulate count, and one more major thing like heavy metals, which important heavy metals including lead, cadmium, mercury, chromium, and nickel. These ions you can remember your +2 studies. These heavy metals are widely known as contaminants of aquatic system, soil, and the atmosphere, and are harmful even in the minute concentrations. The source is human activities such as mining, fuel combustion, agriculture activities, landfills, sewage have been recognized as the key sources of heavy metal pollutions. We are polluting ourselves, nothing but. We are contaminating all the things and we are taking it back again. So we have to bear it. That's what. And one more thing is pesticides. Pesticides chemical compounds are used in various agricultural practices to kill pests, including insects, fungi, and unwanted plants. Over 1,000 different pesticides used around the world in order to enhance food and agricultural production also have drawbacks such as potential toxicity to humans and other species. These are chemical compounds like persistent or non-persistent. A pesticide can be persistent enough to kill or control its target, but must degrade fast enough not to accumulate in the environment or the food chain. So, okay, I'll jump into the topic. See, humans are exposed to numerous kinds of microplastics through ingestion, inhalation, and direct skin contact. Negative impact on air pollution on reproductive outcomes like hormonal disturbances result in erectile dysfunction and sperm count, oxidative stress due to more ROS, result in increase in sperm abnormalities, decrease in count and motility, and increased sperm DNA damage or fragmentation. Gene toxicity causing mutation. If we do so, very soon we'll be like this. As we all are already have experienced during COVID, right? Lack of oxygen. So now coming to our main topic, like why sperm preparation is done. The goal of sperm preparation technique is to enhance sperm motility and viability, to improve sperm concentration and morphology, reduce sperm aggregates and debris. And as per World Health Organization, separating sperm cell from the seminal plasma within an hour of ejaculation to limit damage from the leukocytes and other cells present in the semen. And the final yield should be morphologically normal, motile cells and free from debris and non-germ cells and dead spermatozoa. What is semen and sperm? Actually, semen is a fluid released from the male reproductive system during ejaculation. Coming to sperm, also known as spermatozoa, are the male reproductive cells responsible for the fertilization and egg. So this is what we do actually. The sperm in the preparation technique, we separate sperm from the seminal plasma. And the key difference is composition. Semen is a fluid containing sperm, while the sperm are the individual cells. Semen provides the medium for sperm transport, while the sperm fertilizes the egg. Semen is produced by multiple glands, while sperm are produced in the testes. So this IUI, I'm not going to discuss about this much. I'll jump into the preparation techniques. Sperm preparation techniques. So we all commonly known, common used technique is density gradient, right? So now here today we are going to discuss about density gradient centrifugation, swim up technique, simple wash and centrifugation, glass wool filtration, max and microfluidics. So density gradient centrifugation, simple wash and swim up, we are going to give you a demo and make you to do, and the best reported preparation will be awarded, as Dr. Poornima said. Glass wool filtration is a 2-decade-old technique. Now it's not under process. And max and microfluidics are the advanced techniques. And coming to density gradient centrifugation, is most commonly used sperm preparation technique in fertility treatment, including IUI and IVF. So this is how routine semen sample looks like. And the principle behind density gradient is a separate sperm based on their density and motility using gradient of increased density. Improves sperm quality and reduced contaminants. Like this is what by doing centrifugation, the contaminants and the immotiles and dead sperm all will be separated from the motile sperms. This is what the procedure, like we'll have the layerings, like 80%, 40%, and the sperm will be layered. Layering plays a key role. Whatever you do, however you do, if you skip, if you miss how to do a layer and how to collect the sample from the tube to the conical tube, how to transfer the tube, this plays a very, very, very key thing, very important thing. Everyone thinks that what's there in density gradient? Layering 80%, 40%, sperm, centrifugation, separation, and collecting the pellet, loading in the catheter, and transferring. That's what. But layering, selection of the media, warm media temperature, how frequently you are using the media, how you are maintaining your media in the fridge, at what temperature, how you are thawing the media and taking back to the room temperature, how you are aspirating the media, how you are layering the media. It's a very important thing. And once the centrifugation done for the first step, and second step, very important thing, like because all the debris immortals will be coming up with the supernatant. While aspirating the supernatant, if you miss a drop, your preparation gone. Just the supernatant should not be touched to the pellet. If a drop touches your complete motile sperms, it will be mixed with the supernatant. So density gradient centrifugation is very important thing. Now we are going to do that actually. This is the procedure actually. So how density gradient centrifugation is done? So we are going to give you the kit which contains the conical tubes. This is a 14 ml conical tube, and media also will be giving you, which we have 80% and 40%. 80% or 90, because there's a 80-40 or 95-45, whatever it is, you can choose depending on your embryologist choice and your lab parameters and lab SOPs. And here we are going to discuss about the 80 and 40. 80% is the lower base, and the 40% layering plays a key role. Again, I am repeating this. Whenever you do an IUI, just make focus on your layering. 80%, 40%, and taking the semen sample, which is non-viscous, liquefied semen sample, not a viscous. Whenever a patient gives a sample, you can't directly take the sample from the container and transfer into the conical tube. You have to make liquefied. You have to make sure the sample is completely liquefied. If the sample is not liquefied, you won't get any yield. And whether the frozen sample or donor sample or the fresh sample, if it's a frozen thawed sample, you have to separate the cryoprotectant from the sperm, and you have to do the centrifugation. If you take the frozen sample directly and do the density gradient, you won't get any yield. You may get but you won't get a good motile and morphologically normal sperm through the procedure. You may be thinking, the guys who are doing IUI, what is their density gradient? Why this guy is telling this, making this complicated? See, each and every step in the density gradient and the final outcome, whenever you get a pellet also, how much time you are taking for the transfer of the sample to the catheter, how you are loading the catheter, and how inclined you are incubating the media, and how you are overlaying the pellet. Each and every step plays a key role in the success of an IUI. So whenever we are taking 80% medium as a base, lower base, and 40% in the upper, and it's a 1 ml of 80 and 1 ml of 40, overall 2 ml, and 1:1 ratio, 2 ml of media, we have to add 2 ml of liquefied semen sample. No matter if a patient gives 1 ml or 1.5 ml, we can add, not an issue. But more than 4 ml, we can't take in a tube. How much if we give more than 2 ml, 2.5 or 3 ml, we have to take only 2 ml. 2 ml is a cutoff for the value. If the patient gives 1 ml, you can take, no problem, 3 ml, and opposite balance should be the 3 ml. And centrifuge it for 12 minutes for 1200 RPM. Then after you have to separate the seminal plasma, like whatever the superintent you got in the top, the pellet will be settled down. Then you have to add the wash media again for the 1:1 ratio with the 5 minutes of centrifugation for 1200 RPM. Then you have to mix up the pellet, and you can overlay with the media, either wash media or culture media, whatever you choose. Overlay it and incubate for a minimum of 10 to 15 minutes. Then the loading of catheter also plays an important thing. You have to, as you all know, I think how much we can take in the catheter, like a 1 ml or 2 ml or 3 ml. Am I correct? I think 0.5 or 1 ml. Fine, thank you. So from 0.5 to 0.8 you can take. So loading the catheter also very important. And after loading, how you are transporting from the loading to the transfer room. That also plays a key role. So that's what the gradient. And why double density gradient centrifugation? What is double density gradient centrifugation? It's a sperm preparation technique used in the ART to separate motile, morphologically normal sperm from the debris, dead sperms, and seminal plasma by layering semen over two different density gradient centrifugations. And what is the purpose of sperm washing using density gradient centrifugation? To isolate high quality sperm with good motility and morphology while removing dead sperm, leukocytes, bacteria, and seminal plasma, which can contain ROS that may damage sperm DNA. And the key components of used in double density gradient media are, as we said, 90% or 45% or 80 or 40%, composed of colloidal silica particles coated with silane to create a stable gradient for sperm preparation. And the two density layers used instead of why are two density layers are used instead of a single layer gradient? Double density gradient layer improves the separation efficiency by allowing progressive elimination of immotile and morphologically abnormal sperm as they pass through the both gradients, ensuring a purer sperm fraction at the bottom. And the advantages of double density gradient: selects highly motile and morphologically normal sperm, reduces contamination from the WBC and bacteria, and minimizes oxidative stress by removing seminal plasma, and suitable for various ART procedures including IUI, IVF, and ICSI. And the limitations: some sperm lost during the processing, because this is what pre and post wash count is very important. Whenever you are analyzing, when you are going for a double density gradient or sperm preparation technique, pre-wash you have to note down, and you have to check the pre-wash and post-wash. Why it will be lost? Because whenever you are counting, you may get the count. It includes motile, non-motile, immotile. The count contains everything, so that you may get around 45-50 million. Whenever a gradient precision post-wash, the count will be like immotiles, dead sperms, and the debris will be separated. You may get a yield of a highly motile sperm. So it may, there is a loss of some sperm like a count, and may not be ideal for severely oligospermic samples, low count. Centrifugation can cause sperm DNA fragmentation in certain cases. How does sperm selection via density gradient compare to swim-up techniques? Like density gradient centrifugation provides a higher yield of motile sperm and is better suited for samples with poor motility, while swim-up is preferred for normal spermic samples with high motility but may yield fewer sperm. And can density gradient centrifugation be used for sperm DNA fragmentation testing? Yes. After processing, sperm can be evaluated for DNA fragmentation using tests like tunnel, CSS, and comet assay. But now, as of now, everyone is doing SCD, sperm chromatin dispersion assay. And is this technique effective for the sperm retrieved from the testicular or epididymal aspiration like TISA or PISA? No, we can't do density gradient for the SSR, surgically retrieved sperm, because density gradient centrifugation is mainly used for the ejaculated sperm or frozen thawed sample. And testicular and epididymal sperm requires different preparation techniques such as direct washing or microfluidic sperm separation. And coming to swim-up technique, it's selects motile sperms by allowing them to swim into a separate medium, leaving non-motile and debris. Reduce sperm with poor morphology, you can see here, it's a very simple thing. You have to add the media and sperm with a 1:1 ratio. If you have a 1 ml of semen sample, add 1 ml of liquefied 1 ml of liquid semen sample, you have to add 1 ml of wash media, and just in swim-up technique, there is no centrifugation required. You just add the media with the semen sample, mix well without having any air bubbles. Avoid air bubbles. If you get an air bubble in the tube, polynomial conical tube, you can't get a sperm to swim up, because whatever the sperm swim up, it will be stuck in the bubbles, right? So whenever you are removing the bubble, obviously a motile sperm will be taken out. So you won't get a good yield. So this is the only technique which we can do without centrifugation.